Well, good morning, good afternoon, everyone. My name is Dr. Jim Geiling. I'm a professor of medicine at the Geisel School of Medicine in Hanover, New Hampshire, and a practicing bedside clinical critical care provider at its affiliated VA, a Veterans Affairs Hospital in White River Junction, Vermont, and also a tele-ICU doctor for the Dartmouth-Hitchcock Medical Center. As part of the CHEST ongoing program to address the challenges related to the COVID-19 pandemic, many of the viewers and members of the CHEST organization have expressed some concern about what is the moral distress, the psychological, mental health impacts of this pandemic, not just on the patients that we see, but also on the healthcare workers themselves. And so as we continue to progress through this ongoing pandemic now with the progression of the Delta variant throughout not only the United States, but worldwide, it's an appropriate time to sort of begin to look at these kind of impacts, both again on patients and the healthcare workers themselves. So I'm pleased this afternoon to introduce Dr. Sonia Norman. Sonia is the director of the PTSD consultation program and professor of psychiatry at the University of California in San Diego. She's a clinical psychologist and a researcher in the treatment of PTSD and addictions and novel treatments to address trauma-related guilt, shame, and moral injury. She's based at the Veterans Affairs facility in San Diego healthcare system, where she previously directed the PTSD treatment program for veterans who served in Iraq and Afghanistan. She has over 170 publications related to PTSD and associated problems, and has grants funded by the VA, Department of Defense, NIH, and others. And she received her PhD from Stanford University. Dr. Norman, thanks so much for being here this afternoon, and I'll turn it over to you.
My pleasure. Thank you so much for having me. I'm delighted to talk with you today. Let me go ahead and share my screen. So I'm going to talk about a couple of things today. The main topic is PTSD and moral distress in patients and providers. And what I'm going to do is share some research and some resources. So I'm with the National Center for PTSD, which is within VA. And the National Center for PTSD is funded by Congress and by the VA. And we have 7 sites that do a combination of research and educational activities that really position us as the leader in PTSD in both the US and really much of the world, or a leader. And today I'm going to speak with both hats, my researcher hat and my educator hat. And what I mean by that is that I'm going to share some research with you about some of the things we're learning about moral distress in healthcare workers. And I'm going to share some research with you about what we're learning about mental health in general during the pandemic, both by the broader public affected by the pandemic and those who've survived COVID-19. And then a large part of the talk will actually be on resources. So these are products developed by the National Center for PTSD, freely available to everyone on our website, that are really designed to help the general public, to help healthcare professionals, tools for healthcare professionals to use with patients. I'll show some ones that are particularly relevant during the pandemic. So let me start by talking about healthcare workers. It was really interesting to see right at the start of the pandemic, within, I'd say, the first 3 to 5 months, definitely by this time last year, there were well over 10 to 15 kind of letters to the editor and opinion pieces in, very high-end journals like JAMA and such about the moral impacts of the pandemic on healthcare workers. And the speculation was that these were such unusual circumstances that certainly healthcare workers would be feeling these moral effects. What was interesting and made sense because it was so early was that there was really no data at that time. So there were these great pieces by these great minds, but they were really opinion pieces. So we were really interested in actually collecting data on this. And I believe this is actually still one of the only publications out there with data on moral distress in healthcare workers. So I'm going to walk you through at a pretty high level because I want to keep this talk brief and really have a lot of time for discussion. But I will walk you through at a kind of a high level of a study we did, and then I'm happy to go into further detail. So this was recently accepted in the Journal of Depression and Anxiety, which is a psychiatry journal. So the idea that we were trying to pursue was that we know that healthcare workers in general, doctors, nurses, others, they're trained to deal with crises. They're trained to see death and dying. It's not like this is new or shocking or automatically stops healthcare professionals in their tracks. But we also saw that the pandemic was making certain healthcare workers confront a lot more of this than they usually do, and under circumstances that may have challenged their morals and ethics about how things should work. So maybe it's because they didn't have enough resources. Maybe it was because they were being hit with so many patients that they couldn't give patients the care, the level of care they wanted. Maybe it was because they didn't have the tools they normally had. I mean, early in the pandemic, we heard about, people in general medicine being moved to pulmonary and being asked to do these very high level things that weren't part of their standard practice. Maybe they were seeing patients die alone in isolation away from family, and that felt very wrong to them. So the pandemic just raised a number of circumstances for all of us and anyone, but particularly it seemed for healthcare workers that could really kind of lead to this sort of moral distress. Like, what do I do with this distress of having to take part in these situations that don't feel right to me, and sometimes day after day when I'm really exhausted? And one of the things we know about this kind of moral distress in the moment is for some people, this can become moral injury. So, many of us will find ourselves in morally challenging situations from time to time that can feel very distressing. And for the most part, people that resolves. But for some, it can continue, and it can become this really deep pain, kind of existential pain that continues. And we call that moral injury. It can be spiritual, it can be emotional. And what we know is this type of moral injury is actually related to greater risk of depression and anxiety and post-traumatic stress disorder, and sometimes even suicidal ideation. So what we wanted to see was what were healthcare workers experiencing. And we had the opportunity to collect data on over 2,500 healthcare workers in New York City during that first surge last spring. We had them complete a survey. There really was no survey of moral distress during the pandemic, so we created our own items. And looking at the literature around moral distress, these were really about feelings and worries. So we had the 2,500 healthcare workers complete the survey, and we looked at prevalence of these various items, and we did a factor analysis, and we found that they fell really into worries about loved ones, like feeling torn between work and taking care of family, worrying about how taking care of COVID patients would affect family members, children, dependents. Remember last spring, people would actually move to hotels and just see patients around the clock in their PPE that they were lucky to have, and sometimes not go home for weeks. We had items around worrying about infecting others, infecting patients, infecting colleagues. And remember, again, this was last spring when we knew much less about how the virus was transmitted. And then there was a lot of worries about just, can I do this work? Am I doing enough? Can I do enough? Do I know what I'm doing under these circumstances where I've been thrown into something that's very different than my normal job? So that's kind of the three factors that we saw. And what we found was that these various factors, between 50 and 87% of the healthcare workers endorsed them. So they were very common. And we also looked at their correlation with post-traumatic stress disorder symptoms, symptoms of burnout, and symptoms and reporting worse functioning at home and in relationships. And they were related, all of them were related to all three, basically. So if you had this moral distress, you were doing worse. And we saw that concerns about work functioning and personal relationships were most strongly related to mental health concerns. So the next step in this is we've actually been able to survey those healthcare workers again, and we want to look at whether that early distress is associated with worse mental health problems down the road. And certainly the pandemic was still continuing, but New York City was in a much better place when we did the second survey. So we'll be able to see sort of what were the lasting impacts of that. So what did we learn from this? Certainly asking how healthcare workers are doing and efforts to prevent distress, prevent these associated symptoms, and even intervention for some people is warranted. And when we looked at the literature and we looked at our own expertise in National Center, we have some people who focus their entire careers at help after disasters, after crises. What we came up with was help across a number of domains. So people, of course, need to take care of themselves. And so some strategies around that are seeking support around difficult decisions, because when you have to make these decisions that have these very big moral and ethical implications, making them alone can feel much more painful after than when you have the support of a group, when there's some consensus, when you've all been able to talk through it and come to something together that can really prevent some of that deep distress. Talking to others, sharing the burden, using coping tools like apps, like yoga, whatever that is for you, as best you can. The other thing we see is that people help themselves by helping others, and that many, even while they're suffering, are very concerned about their peers, their colleagues, their loved ones, and they want to do something for them. So reaching out to others, checking in with how they're doing. Sometimes people feel a lot of pressure to say the right thing or do the right thing, do something to make it better, when really listening is often the most powerful and helpful tool we have. So taking that pressure off ourselves to make it better and just be a good listener is powerful for both parties. And then many of us are also leaders and, and supervisors. So setting up systems where people can take breaks, where they're alternating their work so they're not always doing the most high pressure work. Whereas policies are changing quickly and decisions are made about how resources are being used, there's clear communication about that. So it doesn't seem like it's happening in a black hole and employees are just the victims of these policies, but that they understand the thinking behind them and why things are the way they are. And one of the most effective things leaders can do is normalize getting help. So, because people feel a lot of stigma, even those of us in healthcare feel a lot of stigma for getting mental health care for ourselves, even if we desperately need it. And so creating an environment where that's discussed, where people share that they do that, where it's normalized is very powerful. And there's also interventions for those who really develop that longer term moral injury. So one of the things I developed and study is a treatment called trauma-informed guilt reduction therapy, TRIGGER, and it's for guilt and shame and moral injury from trauma. And we actually have a grant funded by the Department of Defense. We got $750,000 about for a 3-site study for 1 year during the pandemic, and now we're looking for a second year of funding to study if people have this kind of moral distress during the pandemic. If we treat them, does that prevent these other problems? Does it help their mental health? And so we're not only studying healthcare workers, although we've gotten quite a few into the study, but we also have people who couldn't travel to a parent's funeral and they felt like they abandoned the other parent who was there by themselves and they weren't there for this important moment. Again, all those myriad of things the pandemics bring up, we're really learning from our participants. We couldn't even have envisioned the kind of things that they're bringing to us and saying, this is what my guilt is from. So we're learning from them about what's causing guilt during the pandemic, and then we're trying to see if this intervention is effective. So many of these strategies that I've discussed are on our website in a document that's specifically about moral injury with healthcare workers, and that the link is at the bottom, but I'll actually show it to you again later when we talk about resources. So let me talk now a little bit about what we know about mental health during the pandemic in general. I get alerts on COVID-19 and mental health articles, and I would say there's tens coming out every single week. There's no shortage of articles, so you'd think we'd know a lot. And we do. We've certainly learned a lot. We know that people are at risk for depression, anxiety, worse post-traumatic stress disorder symptoms, but a lot of these are snapshots. They're not representative samples, they're convenience samples. The studies are done very quickly. So I would say there's still a long way to go to get kind of really a comprehensive understanding that'll really help us learn for the next pandemic and really help the people who need it. But we were lucky in a way in that we have the study that has multiple data points. It's with a nationally representative sample of veterans. It's called NERVS is what we call it. And we happen to have a data collection point where we sent this survey through Ipsos to over 4,000 veterans really shortly before the pandemic, around like January, February 2020. So we had this pre-pandemic data point. And then we were able to go to National Center and ask for funds to actually get what we then called, we were thinking maybe it would be a post-pandemic data point. It turned out to be a peri-pandemic data point, which was last winter, early 2021. We were able to go back to those same people and collect data again. The sample is a little older because it's representative of veterans. It's predominantly white, and about 35% served in combat. And I want to thank the collaborators, especially since some of them are the ones that put the slides together that I'm about to show you. So we're publishing kind of a few different papers from this. But the first one I want to show you was on increased risk of suicidal ideation. So these are people who didn't think about suicide before the pandemic, but now mid-pandemic or peri-pandemic are telling us, yeah, I have ideation around suicide. I think it might be nice. Which is a risk factor for actual suicidal behavior. So something to be very concerned about. And what we're seeing is that it increased from before the pandemic in every age group, but particularly in this group that was 45 to 59. So the group that's working probably has childcare responsibilities, maybe elder care responsibilities. That's where we're seeing the greatest increase. We looked at predictors like risk factors that increase someone's risk of having new suicidal ideation and protective factors. And risk factors included older age, going into the pandemic with more mental health problems, mental health symptoms, previous suicidal behaviors, which makes sense. Past behavior is a good predictor of future behavior. And having had COVID-19 was a predictor of new suicidal ideation. Protective factors included higher household income, so more financial stability, and a greater sense of purpose in life. So to go into this just a little bit more, we saw that 661 veterans who had depression, anxiety disorder, post-traumatic stress disorder, substance use disorder prior to the pandemic. Of them, almost 20% had new onset suicidal ideation during the pandemic. And this purpose in life finding was very interesting. As people had greater purpose in life, like a 2, 3, 4 is greater, as it goes to the right, they were less likely to have this new onset suicidal ideation. And we've seen this in other studies too, where having a sense of like, I am doing something meaningful, I'm doing something that matters, I know I'm here, that is very protective against suicidal ideation. So clinical implications, those infected with COVID-19, age 45 and older, or with lower purpose in life, were at highest risk. In the mental health field, we have interventions where we really try to get people to think about what they value, what's meaningful to them, what gives them a sense of purpose, and we work with them to align how they spend their time, their work, their activities to those kinds of things that are meaningful to them, so that they're spending more of their life in things that feel like they have a sense of purpose. So encouraging more of that. And for some people that could have a religious or spiritual angle to it. And so we always want to ask about that and help connect with chaplains or others to help them connect with their spiritual community if that gives people a sense of purpose. We also wanted to see these 2 data points gave us a pretty unique opportunity to look at increased rates, because, again, a lot of this research in the last year has been snapshots. Here's a snapshot of how many people in this population are depressed or have anxiety, but it doesn't mean as much if you don't know if that's a change from before. And we had this before data. So what we see is some increase in depression symptoms, in anxiety symptoms, in PTSD, well, actually not in PTSD symptoms, but only statistically significant in generalized anxiety disorder. And then when we looked by age group, we saw, again, it's these midlife people, like I'm sitting right here, these people 44, 64, who are really driving this statistical significance. They were the ones that were really bearing the brunt of being more likely to have anxiety being more common. About 15% had new onset positive screens for psychiatric disorders and risk factors for being in that. And I should say positive screens. We weren't doing a full diagnostic interview. We were giving a short survey. So they were screening positive. We don't know for a fact that they have these disorders. But to be in that 15% that now screened positive that didn't before, some of the predictors of that were actually having fewer adverse events in childhood, having greater alcohol use going into the pandemic, being lonelier going into the pandemic, having less social connections going into the pandemic. Those were risk factors for developing mental health problems. And then during the pandemic, people who became more lonely and people who worried more about the pandemic were more likely to develop mental health problems. And these are correlations, not causation, just to be clear. We also looked at the subsample who had COVID, and about almost 10% of these 3,000 people had COVID. 70% were about mild to moderate, but we had 6% who had an ER visit, or 4.5% who said it was severe, 2% in the ICU, and 1% on intubator or ventilator. And so among those, veterans who had COVID were more likely to screen positive for anxiety disorders, PTSD, alcohol and substance use disorders. Depression and suicidal ideation did not differ between those who did and didn't have COVID. And risk factors for depression, anxiety, PTSD were having more psychiatric symptoms before the pandemic, having more stressors related to COVID. So again, more worries, more social restrictions, financial stress, more pre-pandemic drug use, and actually having had more trauma was protective, was less likely to be related to mental health problems. So that's an intriguing finding. In terms of substance use, people who used more substances and alcohol before the pandemic were more likely to have increased substance use if they had COVID. And related to suicidal ideation, people who were lonelier even before the pandemic, were more impulsive and used alcohol more, were more likely to have suicidal ideation, and having greater, feeling more connected to your community, more integration in your community, and greater household income were protective against mental health problems among these COVID-19 survivors. So we should definitely be monitoring folks with COVID. And this didn't even ask about long haul symptoms, which we know, we're starting to know is related to even more likelihood of mental health concerns. So definitely something to be watching. And those with fewer socioeconomic resources, greater symptom severity before the pandemic, and more COVID-related stressors seem to be, from what we know from this sample, at highest risk. So certainly we're seeing that, as with other studies, there's greater mental health burden with the pandemic. This data is showing us uniquely that the pandemic and COVID are raising certain mental health problem rates from before the pandemic. And those who have fewer resources and more severe mental health symptoms pre-pandemic are particularly vulnerable. And those with more COVID-related stressors and infections really require the most monitoring. So, again, I could give, I'm sure at this point we could have a week-long conference just on mental health in the pandemic alone. So I gave you a very high-level overview of a few of the studies that we've done. And I'm going to turn now to showing you some of these resources. So I'm actually going to stop sharing this screen for a second and share our webpage where we have our COVID resources. So I want to show you what we developed or modified in response to the pandemic so that you're aware of it. So National Center for PTSD, or NCPTSD COVID, if you Google that, this comes up. And what we did is we were developing resources for everyone, for healthcare workers and responders, for leaders. Was at first we just developed things and we realized, oh my gosh, there's so much, we need to sort it somehow. So we came up with these 3 tabs. And I'll just show you some of what we have so you're aware of it and can come back to it in your own work or for, however you want to use these. So for everyone, there's a lot of self-help tools, and there's an app called COVID Coach that I'll show you a little bit more about, but it's kind of a stress management tool that's nice to have right there on your phone. And there's a lot of different resources on managing stress, helpful thinking. For a while, there was a lot of, depending on where you are ongoing, people not comfortable wearing masks. So we developed a document that sort of really tried to be very sensitive to what are your particular reasons to having concerns about masks, and going from there to help people with strategies for that. For family members affected by COVID, a lot of this is also in Spanish. There are resources about dealing with grief because there was a lot of loss during the pandemic. There was increased rates of intimate partner violence when people didn't have their normal support systems and couldn't leave the houses freely. So we have some resources around that. Tips for supporting others and helping others through their grief, and some other related resources. The healthcare workers ones, there's some resources on helping your patients and some resources for yourself and your colleagues. And helping people manage stress, working with patients who've been through COVID, treating PTSD during COVID. Some of this gets very nuanced for people who are treating PTSD, but there are, if you want to learn more about moral injury, there's a page here that really summarizes the research and what it is and what we know about it. And then there's some self-help materials. And this is that page, Moral Injury in Healthcare Workers, that I referenced earlier. This is very specific to healthcare workers and what we know and some strategies, some of which I went over at the beginning of the talk. There's also frameworks. So if you're ever in a situation where you have to go in after a disaster, after, some sort of event that affects a large number of people, there's stress first aid and psychological first aid. So these are manuals that can actually be downloaded. And then additional resources that you can look through. And similarly, the ones for leaders, I won't go into in a lot of detail, but certainly you could look here and see what's there that could be helpful to you. So let me go back to the slides. There we go. So this is a little bit more about the COVID Coach app, just so you could see a little bit about the screens, what it looks like. It's very, very calm. And there's information, education, various tools and trackers and graphs, lots of helpful resources. These are those manuals I mentioned. You can actually download them from our site. And all of this is on that COVID page. And then we have a lot of resources in general around PTSD and trauma and disasters that are helpful and applicable during COVID as well. Jim mentioned the program I run, the PTSD consultation program. So we're available to any healthcare provider to talk about any question related to caring for veterans with PTSD. We can also help you find resources not for veterans. And we're available to email or talk and answer really questions about treatment, assessment, medication. We have tools to assess PTSD, and there's all sorts of tools from ones you would use in other areas of medicine, just as a 5-item screener, to diagnostic interviews that go through every single symptom and ask for examples and take an hour, but really give you a very reliable diagnosis. For those of you who are interested in just screening for PTSD and aren't in mental health, there's the PC-PTSD, which is primary care PTSD, which is a 5-item assessment. And if people, yes, no answers, if people endorse at least 3, that's a positive screen for PTSD, suggesting that more assessment would be useful. And you can download that from our site. You can have these slides, and all of these are live links, but also, again, you can always Google National Center for PTSD, PC-PTSD, and you'll find it, or you could email me or the consultation program, and we'll get these to you. We have some newsletters people can sign up for if they'd like more information on trauma and PTSD, some for the general public, some for health professionals. And then we have tools directly for the public or really for anyone. So if someone wants to learn more about PTSD treatment, the PTSD decision aid lines up all the different evidence-based treatments that really we know work from research. And people can compare and contrast and say, oh, this seems like a better fit for me because I want to take medication, I don't want therapy, or I do want to talk about my trauma, or I don't. And they can learn about what works and what their options are. About Face, just Google About Face PTSD and it comes right up. It's just an incredible resource of hundreds of people talking about their PTSD and how they knew they had PTSD and why they decided to get help and how treatment changed their lives. it's incredible for people who aren't sure if they do or don't have PTSD or if treatment is right for them. They can find someone of their ethnicity, age, sexual orientation. Like, it's a very diverse site. And we have a number of apps. All of these are free. PTSD Coach and COVID Coach. These are all kind of self-help tools. There's some that help people stop drinking. There's a mindfulness coach. So these are all great kind of stress management tools, anxiety management tools. Vet Change is for veterans with PTSD who want to reduce their drinking. So it's kind of specific, but it's a self-help tool. And PTSD Coach Online is for those who want to use the PTSD Coach but don't want to do an app on their phone. They'd rather have their full computer. So those are just a few of the resources. Again, I'm happy to help you find any of these. There's also a lot more, but I'm going to stop sharing now and open this up so we can take some questions.
Yeah, great. That was awesome. So thank you so much for walking our way through this. And for those of you on the call from the U.S., I think it's a really important message here is the Veterans Affairs, your tax dollars, have an incredible amount of resources, not just for the veterans, but for the whole healthcare industry and all of the United States and around the world, really. So thanks to you, Sonia, and all of your team and the National Center for all the great work that they sort of do, which really is a national and international resource. Some of the questions that have come in probably are buried. The answers are buried in some of those resources that you offered, but just a real quick one over. Might you talk about, I'm a healthcare worker. I'm just tired. It was in New York. Now it's popping up in Missouri. Those who are in Indonesia right now. How do I distinguish between I'm just tired and it's actually coming into something a little bit more serious that I need to think about? And then the next step would be, what can I manage on my own? And then what are some warning signs I really need to go get some help?
Yeah, that's a great question, because I think very few of us haven't at some point felt kind of at the end of our rope during the pandemic, right? Some sense of burnout, some sense of just, feeling down or just over it. And that question of, when do I sort of white knuckle through it versus when is it time to reach out for help is a really, really good one. I think we all have the things that help us through a hard time. And those are things that we've learned over time are helpful to us. For some, it's exercise. It's, socializing as best you can during the pandemic. I was lucky here in San Diego to have my backyard pretty much year round. I know that's not true everywhere, but also did lots of Zooming with people all over. So, I think you try those things and you give it a little time and you see, is it kind of waxing and waning, and you can kind of, you feel like it's manageable. Some of the signs that it really is time to kind of do something differently and maybe reach out for help might be if you're feeling down, most of the day, every day, and it's lasting more than a week or two. If you're feeling anxious and amped up and trouble sleeping, which isn't normal for you, for, again, kind of 2 weeks, I would say is a good threshold for, okay, it's not just kind of transient, it's really sticking and it's really affecting me. If it's affecting your functioning, so if you feel like distracted at work or you can't really do your work or you're missing things you wouldn't normally miss, if it's affecting your relationships, so you feel like you're constantly at odds with people because of these, internal feelings, your relationship with your children, with your loved ones, with your spouse feels very different and very negative, and it's not getting better. So those kind of changes in mood, changes in functioning, whether it's at work or in relationships, those are some of the big things that would be a suggestion that getting help would be a good idea.
And how about some red flags for your coworkers? Same sort of thing. Maybe perhaps a little bit more depressed mood, or perhaps even the other way. They're a little bit more over animated and the like. What are some things you can sort of say, okay, I need to go put my arm around this person and just sort of say it's time to go get some help?
Yeah, I mean, honestly, it's a hard line because some people, you'll never know it, right? They won't show any of those behaviors and they may be some of the ones struggling the most. So I think really we have to check in with everyone. And then it's sort of hard because you also don't want to be that person going around checking in with everyone all the time. So you kind of have to find, a comfortable way to do it, or just sort of, I always think about, how do I make myself accessible? How do I consistently make it clear to the people in my sphere that I'm a safe person, that if they're struggling, they can come and talk to me and feel good about it. So I think putting ourselves out that way, being good listeners, being available, casually checking in, I think is really important for everyone. But certainly if you see someone in your sphere who's, just visibly upset or amped up, again, consistently, not in a transient way, but you're seeing it over some amount of time, or you're seeing someone's job performance really affected. And I know I've had the experience where I'm seeing it and they're kind of in denial, right? So that's hard, where you don't want to be like, hey, I see you messing up a lot, if they're kind of not ready to confront that. But I think there's ways to just make yourself available to that person, to just say, how are you doing? Or, let's stop for a coffee, whether that's, in person at the hospital or on Zoom, depending on how we're working at that time.
Yeah, that's great. Those are great points, because I think sometimes we sort of sweep a lot of this kind of stuff under the rug for ourselves and for each other, and then we are taken by surprise when there's an untoward event with a coworker or family member or something like that.
Yeah, and when you do look at just quickly, when you do look at some of this literature around this, I mean, we are seeing like nurses having, rates of suicidal ideation that are really high. These are people all around us, and so the struggle is very real. This is really worn people down at very high levels. So it really is. No one's safe. We really should be checking in with each other.
So it's probably, I'm just looking at our time. We have a little bit of time. It's probably a bigger, obviously a lot larger conversation, but most people on this call are not mental health providers. We're, critical care. We work in that kind of unit. There's an ethicist on the who registered. Can you just walk us through perhaps a few of the options? I decide to go seek help. My friend decides to go seek help. What does the psychologist, psychiatrist think about, and what are some treatment options that people might be looking at? What's out there as on the menu these days?
Yeah, so people are responding to the pandemic differently, and any good mental health professional would kind of get to know you and do some assessment, and try to do it quickly, because we know healthcare professionals are really busy and we don't want to waste anyone's time. And most of the good mental health work now can be done in just a few meetings. It's not, like a psychodynamic therapy on a couch for years at all. It's maybe like, a handful of meetings. So we want to figure out what's going on, and that might, would take some talking and some questions and maybe even some questionnaires. If it's, just stress and burnout, we figure out what's going on and some strategies to help. If there's, if there's a diagnosable major depressive disorder, or generalized anxiety disorder, or PTSD, we have evidence-based treatments for those, treatments that have been studied in randomized clinical trials, numerous trials at this point. So a good mental health professional will offer a treatment that works, because, there's lots of things on the internet, and lots of, just last week, someone was emailing me about sand tray therapy, which is an app where you play with a sand tray. And I'm like, yeah, that's not going to really fix someone's PTSD. So there's endless things out there, but I would look for the treatments that work. So if someone's diagnosed, that's what you would do. And it really is a good time, because it used to be, especially with PTSD, it's actually a newer diagnosis in our diagnostic manual. So really in the last 40 years, we've come a long way. So if someone older comes to me and say, oh, I tried treatment 20 years ago, I would say, okay, forget that. We've learned so much since then. Back then, you were probably told your PTSD was like diabetes. You'd manage it for the rest of your life, but you'd have it. Now we know you can recover. And so in PTSD, we have therapies, we have medications. Some of the therapies that work are prolonged exposure therapy, cognitive processing therapy, EMDR, I know this probably means nothing to most people on this call, but if you're interested in learning more, email me. I'll send you lots of links to learn about it. But the main message I want to share is that these are treatable, all of them.
Yeah, that's great. I know that a lot of healthcare workers, not unlike military folks, try to like gut it through and are a little bit reticent to go see a mental health provider because of stigma, because of don't want to get another medicine, all those other kind of things, historical perspectives and disinformation on the internet. So I think you bring up some really great points as it's 2021 and we have a lot of options. And so I think that that's really helpful. One thing that, from being a veteran myself and also, having been around military veteran personnel for a long time, the PTSD thing can be long-term, or it can go away and come back, a smell, a sound, some sort of other trigger can sort of put that off or can bring a recurrence. There's this sudden urge, particularly in the United States and perhaps parts of Western Europe, to let's get back to normal. And yes, I was feeling bad and all that, but I'm much better. And then wham, something happens. There's a new patient, there's a new odor. I got to put an N95 on again for tuberculosis. Tell us about going forward, and what should we be thinking about recurrence, about flashbacks, if you will, and how long are we ever cured, or is it going to be there around for a while? Can you talk us through that a little bit going forward?
Yeah, for sure. So, in some areas of medicine, we really talk about cures, and that's a really appropriate term. People sometimes ask me, can you cure PTSD? And I don't think that's an appropriate term for mental health. We think more about recovery because it's much more of a range. So what we often see is someone coming in who's having a hard time at work, who's having a hard time in their relationships. Maybe they're using alcohol, they're drinking more than they, think is okay. And where we want to get them is to feeling better day to day, being more excited about life, not drinking in a way that makes them feel bad, feeling more satisfied in their relationships and in their work. And if we could move them from where they are to that part of the spectrum, that's a great road to recovery. Sometimes we have people who have zero symptoms at the end of treatment. I guess you could say they were cured, but that's not really the expectation. The expectation is that we figure out what your goals are and help you get there. And does that mean, again, there's some conditions that you come in positive and after treatment you're negative and you never have a recurrence. Mental health isn't like that. Life isn't like that. Everyone's going to have bad days. Everyone's going to have days where they think about their worst memory all day long and get wrapped up in it. And certainly it's the same for people, even if they did great in treatment or are generally feeling much better, they'll have really hard times. What the data shows us is that people who've had treatment and generally have resolved a lot of their symptoms, they will have those times, but the lows aren't as low and they don't tend to last as long. So again, those kind of waves of life tend to be better. And certainly, again, we used to think of PTSD as this life sentence, and veterans would come to the VA and they'd keep coming and coming and coming, 30, 40 years. And now the expectation is, why would we want to make you a lifelong patient? Why would you want that for yourself? So you come, we'll do an evidence, we'll do a round of treatment to meet your goals. Once you're feeling better and ready, you don't need to come back, but we're here for you. If you need another episode of care, if you hit a hard patch, we're here for you. So it's more episodic and need-based, understanding that people will go through hard times again.
Excellent. Thanks. Well, I put out a call for any last minute questions in the chat group, and nothing's popped up. So before we sign off, Sonia, any other last minute things or any other kind of summary wrap up things you'd like to talk about?
No, I really appreciate the time. This is such a great audience to present to, and nice to present on these issues to folks outside of mental health. But if you do have further questions or are just looking for some of these resources that I mentioned, seriously feel free to reach out and email me directly or at ptsdconsult@va.gov through the consultation program, and we'll help you find what you're looking for.
Excellent. Well, that sounds great. Well, again, many thanks to you for your time this afternoon, morning, wherever people happen to be, for for tailoring the presentation to a bunch of non-mental health providers to sort of make it applicable to us, and really for everything that you and everyone at the National Center are doing, again, not just for veterans, but for the nation and internationally. So thanks so much to you and to everyone else for joining the call, and you all have a nice day and stay safe out there.
Take care, everyone. Thank you, Jim.
Bye-bye.